Good afternoon. Welcome to a novel demonstration of HIV Navigation Service evaluation. I want to tell you that we are muting all lines so that we encourage you to use the chat box to not only pose your questions for the moderator to each other, but to engage in an interactive session throughout this interactive webinar. To the right underneath the picture, it's the link to the PWP in Action actual video. It's about a 30-minute video. You can see it. It's through http effectiveinterventions.cdc.gov pwp./story.html. This purpose of this actual navigation video is not only to look at evaluating how we look at HIV or navigation service programs and actually the staff, but the real important role that navigators have in improving people's lives. Through the use of this video, as illustrated, you'll see that it is, particularly with the PWP in Action online novelette, that navigators really play an active role in getting people into care and to making sure that they're receiving follow-up and that their data really can drive a difference in their lives. The fact that data is going to be discussed is not to say that data is going to be in metrics as well as techniques for data are going to be prescribed. Evaluation is a systematic collection of information about some or all aspects of a program to guide the judgments or decisions. So evaluation can be formative, such as a needs assessment or process. It can also be summative, such as outcome evaluation. Now, you'll see through this online video, this interactive webinar, how data will factor in. It'll be something which will encourage the use of evaluation planning from the very beginning. You'll see that people will be coming together from different collaborative entities and how they'll be talking a lot about data. So as each individual plans her or his program, it's always important to start with a plan on evaluation at the beginning. Evaluation cannot be stressed any more than that. It has to be something you think about how you're going to collect the data, who's going to collect the data, where the data is going to be housed, how it's going to be analyzed. All that needs to happen at the very, very beginning. So we won't go into a lot of the facets of that, but we will talk at a different, higher level, not only about some of the ways in which you can track evaluation, but why it's important. I'm Robin Kelly, the evaluation manager. The presentation will be given by Mr. Eric Abdulatif. Mr. Abdulatif is a monitoring evaluation consultant and a certified project manager. He's helped organizations to learn, improve, adapt, manage risks, and make evidence-based decisions. So again, through this evaluation, our learning objective, through this webinar on evaluation, our learning objectives will be to describe how an HNS as a service delivery opportunity really helps consumers obtain timely and essential and appropriate HIV-related medical and social services to optimize their health. We'll be using this video, again, the PWP in Action video. The link is again under the picture. That really will let us look at some of the complexities and problems and ways in which navigators really go about their job. We're going to put a cautionary note. There are going to be a lot of ways in which some of the characters in this novel go over and above what is anticipated and expected. So it's not, again, a prescriptive one-size-fits-all depiction of navigation nor evaluation. These are just signs and at a higher level, a way for us to have a larger discussion about the importance of evaluation and data as we go through your program and development. In other words, one of the objectives is to look at the framework and process to enable organizations to really survey, to assess, and then to take that information from their data to improve the functionality of their HIV navigation programs. If they do not have a program, to consider these components as they begin to construct or think about developing such a program. And finally, we want you to have we have some resources listed and some that have been uploaded, and hopefully they'll be helpful to you in your own HNS or HIV Navigation Services journey. So with that, I'll turn the program over to our presenter, Mr. Eric Abdulatif.
Okay, thank you, Robin, for the opening remarks and introduction. We'll start with, we'll skip this poll and we'll go right to the first scene setter. To give you a little orientation to the video novel, if you haven't seen it, we are really highlighting two of many cast members in the online novel. We have two people whose portfolio most look like navigation portfolios, although they're recruited and their bios are in the video for further detail. But as you can see, we've chosen a man and a woman, and gender might be an implication for the kind of work that you have your navigator do, but that's something that, again, needs to be articulated in your plan. And we have Jan Marino and Stu Phillips, who are two people who do various facets of navigation in their work. And I will just minimally say that Stu, in his bio, disclosed his status as positive, HIV positive, and that has implications for his, what we call relatability or likability in terms of being able to work proactively and authentically with people who are in the HIV population and or at risk of HIV. And so we want to highlight those as nuances to the recruiting and retention of navigation professionals, which will in one way or another impact their performance. So those are just, you know, things for you to consider. Let's see. Okay, I'm moving along. The next facet of the background that I would like to share with you is that this demonstration of navigation integrates the work of 3 partner organizations. One of the partner organizations is the health department, along with this health department collaborates with community-based organizations to fulfill the goals and objectives of the National HIV/AIDS Strategy and CDC's High Impact Prevention Initiative. And Positive Empowerment is the community-based organization in this demonstration and has a long history of providing HIV prevention services, including HIV counseling and testing and street outreach. And they provide free lunch to clients, and they also render housing assistance and support groups. Again, their portfolio or their project design may mirror yours in some ways, but it's not, as Robin said, intended to be prescriptive that all HIV navigation initiatives have this mix of services. So, you know, that's just something to keep in mind. But you'll see those aspects of the assistance.
And Eric, as we discussed a little bit ago, a lot of these CBOs, community-based organizations, often have to partner with health departments or clinics, and we always encourage partnership, but we also encourage the discussion of data sharing or data non-sharing, certain restrictions along the lines of privacy, confidentiality. Those things need to be factored in at the very beginning so that a community-based organization's navigator does not falsely say that, oh, I need to get the labs from the clinic so that I can better monitor my my client, my person I'm working with. Mm-hmm. So we all understand that there are limitations to data, but we do encourage that they be worked out, and they can be worked out. We have a lot of tools and fact sheets. In fact, we have a whole series on collaboration and what that can look like in terms of evaluating collaboration. But what's most important to underscore, again, is that you need to start a plan about evaluation from the very, very beginning, particularly even more so when you're dealing with other partners, such as a clinic and a health department, if you are the CBO.
Okay, thank you, Robin. And the last partner that we're highlighting is the Community Health Clinic, which is a federally qualified health clinic. It prioritizes newly diagnosed and lost to care and lost to follow-up people living with HIV/AIDS for appointments, and encourages all people living with HIV/AIDS to start ART. And so that's their mission. And so in the graphic, you can just sort of see that there's logistics between where the partners are located. And of course, you have your navigator working within, you know, these different spaces of their home office and the clinic, and their health department partners have to, you know, have transit. And so transportation is something that a navigator would routinely need, and or communications equipment like mobile phones or what have you. So those are expenses and designs in the project that you should be cognizant of. And so we're going to jump into the first scene, which is going to be at Stu Phillips' office. And Stu is, I think, the doctor in this case, the clinician in this case, and at the Office of Positive Empowerment. I'm sorry, not Stu. Stu is the navigator. I apologize for that. And they're talking about numbers, and we'll get back to what numbers they're talking about and why they think they're important, or why are they raving about them.
Stu Phillips' office at Positive Empowerment.
Stu, fantastic numbers. You found and linked more HIV cases than any other agency we fund.
Good to hear that all our time and effort in the community is having results.
Working together means that more people living with HIV will have an undetectable viral load, and that means fewer new infections. You are really making a difference.
Thanks.
Carlos at Parkside Clinic needs me to stop by about a clinical care issue.
Say hi for me. He's great about working our clients in quickly.
I'll tell him.
I'm out of here too. Jan and I are working in Parkside today.
Okay. So essentially, what Frances Holden is talking about first of all, you should appreciate that Frances Holden is at the health department and works closely with Stu, who is the navigator, and they're talking about the reporting process that they have established, which we don't have a great deal of detail on, but we can imagine that it entails some metrics around his activities around outreach and getting people into care, and those are the numbers that she was suggesting were good and impressive and would be part of the navigator's role to capture those data. And so those reporting requirements would be in the agreement with the health department, which we're assuming is the funder or donor in this case. And we are going to be capturing the information that we're required to capture, but we're also going to be capturing information that's useful for the management of the program and the supervision of the navigation professionals. And so that's something that needs to be thought out and articulated well in advance. Robin, did you have anything to add about that? I would like to also talk about, note the tension between reporting requirements that are set by the funder and those that are for internal and or external stakeholders, and the opportunity to augment what's required with what's useful. And so, you know, time is limited, resources are limited, and the capacity for many community-based organizations in particular are quite limited in terms of what they can reasonably be expected to do with regard to capturing and reporting data. And so that's a negotiation that has to occur with the partners. And as Robin highlighted, any systems about data sharing or any technologies and confidentialities and requirements for HIPAA, et cetera, need to be taken into consideration. Okay. So we're playing another video now.
Stu Phillips' office at Positive Empowerment.
Stu, fantastic numbers. You found and linked more HIV cases than any other agency we fund.
Good to hear that all our time and effort in the community is having results.
Working together means that more people living with HIV will have an undetectable viral load, and that means fewer new infections. You are really making a difference.
Thanks.
Carlos at Parkside Clinic needs me to stop by about a clinical care issue.
Say hi for me. He's great about working our clients in quickly.
I'll tell him.
I'm out of here too. Jan and I are working in Parkside today.
Okay, that was a repeated video. Moving along to slide 9, we have the types of HIV-related services that navigators can assist their clients to have access to. And I want to take a second to talk about the types of indicators that are candidates for monitoring and evaluation. And one of them is at the output level. And output measures that are related to HIV Navigation Services are perhaps the easiest to monitor and evaluate, but they are not necessarily the most useful or compelling. And I've cited a slide here from the National PrEP and HIV Navigation Landscape Analysis that NMAC sponsored. And you can see here that the number of people tested, the frequency of, these are the services that are offered by CBOs is what there are. And so prevention services that were delivered and HIV testing services that were delivered and linkages to care as a unit of analysis are things that people are most commonly tracking around, along with medication, getting people access to medication and providing case management services and behavioral health initiatives are other things that HIV navigation navigators are trying to get clients to access to. And so those are sort of the outputs of the program. They don't tell you quite as much about what happens to the client once they're in the system in terms of, do they get access to medication? Do they adhere? Do they become virally suppressed? Those are the high level outcomes which we would like to encourage that you include some outputs and some outcomes in your monitoring and evaluation performance measure dashboard or key indicator dashboard. Okay. And so we're moving on to the second scene, which is gives an example of the sort of outreach and public engagement aspect of what navigators can be tasked to do. Not all organizations use navigators to actually go out and recruit, but it is a common practice to do outreach, and you may want to consider doing outreach. And we can talk about what successful outreach looks like once we've watched the video.
Early afternoon the same day, intersection of 13th and Crosby in Parkside community.
Is that RJ? I haven't seen him for weeks.
Do you think you'll ever let us test him?
Time will tell. I'm gonna go talk with him.
Okay.
Hey, RJ, how's it going?
Oh man, here we go again with the condoms.
Hey, just wondering what's up.
Well, listen, I didn't need to talk to you. I'm pretty sure I have something. It burns like crazy when I pee.
Yeah, you need to check that out.
I know. Damn it, I can't afford to see a doctor.
I'm pretty sure the Parkside Clinic will treat you free of charge. I can get you seen today. We better get going.
Yeah, I guess. But I got to meet somebody here at 6.
Gotta tell you, they're gonna want to do an HIV test.
Why?
They test everybody now. It's routine.
But why?
Because if you know you have HIV, you can get treatment to help you stay healthy and stop it getting passed on. could do a rapid test right now. That's just a swab in your mouth. That may speed things up a bit.
Okay, whatever. I need this burning to stop.
Stu administers a rapid test and gives RJ his positive result.
Okay. And so what we would like to sort of highlight is that you have to have a plan for what your navigator is actually, his or her activities entail. And in this case, we have a situation where Stu, the navigator, is administering testing, and that might be a skill that you would recruit when you hire or your navigators, or train them on how to do this if this is part of your design. It doesn't have to be. You could simply escort them to somewhere where they could be tested rather than do the testing in the field. But this is an option, and it is a program design issue that you have to sort of work out. You also have to work out the outreach engagement, where are you going to undertake this outreach engagement? Is it going to be at online? Is it going to be at common areas? Is it going to be, are you going to expect the navigators to hold community events? And those would be part of the outputs and deliverables of the navigation program, and the duties and responsibilities of navigators. And you would have to sort of plan and that into the number of navigators you need, etc. And some of the other promotional channels that you could consider would be, meeting people one-on-one and taking appointments, or referring clients to the navigator through either the clinical side of the house or the counseling side of the house, or upon request. And there's some discussion in the literature about gender, giving people the option of preferring a male navigator or a female navigator if you have the luxury of having both. You could give consumers some choice, because some people prefer working with people of the same gender, or that, etc. You could do text messaging, you could have printed materials, you could do email announcements, but those could be in the responsibility of the navigator, or they could not be. And either way, you have to have some goals and monitoring around how many contacts and events and web social media activities you plan for the navigator to do, and have some means for validating that he or she has produced what was desired. And so that's your data. Those are some of our data-driven recommendations, because ultimately you want to be able to determine the level of engagement, whether you made the number of contacts that you wanted to make, why not, how can you improve your outreach, and those data points would help inform that. Okay. And we're going to talk about, those contacts will help you validate whether or not your clients are what we call lost to follow-up or not. If people aren't responding to your contacts, your calls, your emails, your appointments with them, at some point you have to decide to disenroll them, and that's a business decision that will affect your program and the effectiveness of your program, because loss to follow-up, as we will discuss in greater detail later, is one of the indicators that are key indicators for navigation. Okay. So here's a second.
Early afternoon the same day, intersection of 13th and Crosby in Parkside community.
Oh, God. Okay, sorry, that was an error. We want to go to slide 12, and we want to highlight some of the National Landscape Survey findings about how you promote navigation services. And when asked, roughly, you can see here that one-on-one consumer discussions was one of the most frequently used ways to orient people to the opportunity to take advantage of navigation services, followed by, I would say, followed next by the green item, which is printed materials were used to promote the navigation, and then equally group discussions, websites, and social media were used to promote the navigation services. Okay, and there are some differences, and the other two graphs show you HIV navigation from PrEP navigation, which we're not going to get into very minutia, but would like to highlight that a navigation that's general to people that are for HIV should be distinguished from navigation for people who are considering PrEP, because the skill set for the navigator would be different. You could have a navigator that's tasked with doing both, but that would be part of your program design. And that's probably enough to say about that at this time. We're going to move on to the next scene, which is scene 8 in the novel. Carlos's office in Parkside Community Health Clinic. And in this case, Carlos is the clinician. I got him confused earlier. Getting newly diagnosed consumers into care and stable housing are two of the points that are highlighted in this video, and we'll talk a little bit more about it.
Later that same afternoon, Carlos's office in Parkside Community Health Clinic.
So the doctor gave me a shot and a pill for gonorrhea and the condom talk. I'm supposed to come back Friday at 2.
For the follow-up HIV test result.
Yeah.
How about I meet you here Friday at 1:45?
Yeah, sure.
And Francis Holden from the health department needs to talk to you about your partners, who might have infected you, who you could have infected.
Man, I don't want people knowing I have an STD.
Don't have to. Francis can keep your name out of it. How are you feeling?
Okay, I guess. Or I will be soon.
So, where are you going from here?
To meet the guy I'm staying with.
No place of your own?
Not now.
Sometimes there's housing help available for people living with HIV.
After Friday, once you know your HIV status for sure, we'll figure it out from there.
Yeah, okay.
Let's catch Francis before you go.
Later.
Okay. So I would like to sort of highlight that in this video, we see the navigator, the consumer or client, and the clinical care person in the same room having a conversation that may or may be normal for your organization, or it may not be. And it just depends on the design of what you have your navigators actually doing and what access they may or may not have to the client's case detail. And we also wanted to highlight that in this example, the navigator is recommending, offering the ability to be able to help the client secure housing, which would entail having a partner that you're working with that does housing, or having some internal capacity to assist with housing. And that's a program design issue. Or it may be a partner that's a part of your team. Now, in this particular collaboration, we didn't have a housing assistance organization as a member of the team, but hypothetically, you could have a housing partner if you so chose. So that's, but not everyone is required to do housing in HIV navigation is a point that we wanted to stress. And we wanted to also stress that Stu, the navigator, may or may not have access to the consumer's records and files. And it's not clear in the video how these details about what his needs are and what the plan is for this client hasn't been really well articulated in the video, but we want to encourage a care plan and some agreement and some I would like to say, sustainability that we want to get to with a client of navigation, because it shouldn't necessarily be open-ended and ad hoc. And how data are recorded and reported isn't really discussed in the video, but we want to highlight that what happens on the clinical side of the case and what happens on the navigation side of the case may be deposited in different databases or in different files. And those are things that need to be, of course, worked out by each organization that's contemplating or executing a navigation demonstration program. Moving along to scene number 10, we're going to be in PARKSIDE Community Health Clinic, and we are going to see another example of HIV Navigation Services. And we want to take away some challenges that this particular consumer has and how the navigator is interacting with the consumer to try to overcome certain barriers. And we're going to talk a little bit about barriers.
That Friday, Carlos's office in PARKSIDE Community Health Clinic.
What did the doctor say?
That I need to take pills because I have a lot of HIV in my blood.
Right. That's called having a high viral load. The medication will lower it and help keep you from getting sick.
How do you feel about that?
Okay. But she made such a big deal about taking the pills every day.
Missing doses could lead to drug resistance and the medicine could stop working. Also, do you use anything to get high?
So it's no big deal.
It could be. HIV meds don't mix well with street drugs like meth or coke.
I got this, man. I'm not.
An occasional use can be a problem.
I said I got this.
Okay. Did Dr. Sutton talk about safe sex?
You know her deal, don't you?
Yeah. Sometimes people don't realize that even when their viral load drops way down, there's still a risk of transmission.
And you have to use condoms, I know.
We'll schedule you back in a month so Dr. Sutton can see how the meds are working. You'll also need to come by the lab a couple of days before to have your blood drawn.
Why?
So she can talk with you about the blood test results when she sees you.
Man, that's a lot of back and forth.
Bus passes might make getting here a little simpler.
Cool.
I also might be able to pick you up sometimes. I'll call you and we'll work it out.
Don't have a phone. It got cut off.
How about walking over to Positive Empowerment with me? We can see about setting you up with a prepaid cell phone.
Sure.
If we go now, you can get something to eat. Clients can have lunch free every day.
I am hungry. That sounds good.
Okay, so there's a lot going on there, and we want
Friday.
And so what we would like to sort of leave you with is that there's a lot of research around navigation, and the whole point of it is to get clients over the various barriers to accessing care and self-sustainability. And some of the barriers that have been identified in the literature are listed on the slide, and I won't read them all to you. However, every navigation program sort of has the opportunity to decide what barriers their particular navigation program is going to prioritize and focus on, and that should be germane to, that should be relevant rather to the clients that you're working with and their particular experience, and what resources you have to help them overcome the barriers that they encounter. And so you may have someone with a particular language ability if you're working with a population of a particular language background or ethnic background or cultural background. You may have a particular focus on stigma or helping improve people's food security. As we saw in the video, this particular navigation program provides meals, and so forth and so on. But these need to be sort of intentional and designed, and your navigator, of course, needs to have skills in helping people surmount these types of barriers. And in the case of homelessness, you know, the housing piece would be essential, whereas in a and you might have a partner that's on board your program that actually provides that, if that's going to be the intent of your program. And so we would have given a poll here, but we're just recording this video. But think about what your organization currently does and doesn't do, and whether or not you might want to do a needs assessment to find out what the barriers, or when you do your intake for someone into navigation, you might want to be able to highlight what the barriers that they feel are impinging on their health and well-being, and design a plan that helps them address those specific barriers. And I want to say that quickly, that getting a client over barriers, that time and energy that you spend working with them on whatever barrier they're experiencing, is what we call an output. But when people actually have a housing, that would be an outcome. And so it may take more than the time that the navigator spends with a client to actually secure the housing, in which case there would be no data about the outcome at the outcome level for housing. But this is something you have to think about. The output of merely referring someone to housing is the lower level of data, which is important to capture, but it's not as compelling as actually getting someone into secure housing, which would be an outcome, which might take longer. And the same thing about changing people's feelings around stigma and the type of data that you would need to determine whether or not they're how impacted they are by stigma has changed, would require much more research than many community-based organizations can do on their own without having researchers on their team and or research dollars in their budget.
As Eric was saying, a lot of our work is based upon the planning, and the data factors into the plans. So understanding some of the barriers that people experience can be life-changing for the person as you bring it to light. You know, is the barrier stigma? Is the barrier really looking at access? So helping that person understand why he or she is not adherent or able to move forward can be a way in which you can make a difference as well using the data. We were going back and forth, and as people know, when you do your evaluation plan, one major component of a plan is a logic model. And so as we were referring to the inputs and the outputs as well as the outcomes, we're really just thinking of a logic model. A logic model is not in a plan, but it is definitely a component that's often used with evaluation planning. Evaluation planning definitely looks at the questions that are asked, you know, the indicators that help support or get findings for the question, looking at the mechanisms in which you're collecting the data, be it maybe a tablet or electronic format if you're doing outreach versus paper and pencil format, etc. But again, the flow, the way in which it can factor into decision making is usually done through the logic modeling. When you have the activities, when you have the inputs, first of all, when you have the activities that you're doing, like outreach, like testing, whatever it is, then you look at the outputs, and that's kind of more the process measure. How many people did you reach? How many tests were positive? Those kind of hard numbers. And finally, the outcomes, where we're looking at more of the upper level of what do we hope to have achieved? Did we change the knowledge? Did we change the behavior? What are some things? Are the barriers the same? Can the barriers be adjusted, or somehow solutions for these barriers be found? That's kind of the outcomes that we hope to work with the client to overcome. And then finally, the impact, if that's something that's possible, that long term, as Mr. Abdul Latif mentioned, the loss to care, when you get people back in care, how do you prevent that care? All this is part of the plan, and these are definitely the evaluation tools that many of you have used before, and we'll just reminding you how to use those in making decisions, particularly when you have an HIV navigation program. These are all things that are in your toolkit. These are which you can begin to look at, but differently, so that you can see in a different conceptual way, hopefully illustrated through this video, how these things are impactful, how the data can really matter, and what you need to sort of begin to ask for as well as collect. Finally, as we talked about, as Eric mentioned, you don't have to do all the things that you've seen, like bus passes or lunch or prepaid cell phone. That's a lot, and it depends upon you as you develop your plan for your navigation program, or as you look at your navigation program, what is it that would be more helpful for getting your clients over a barrier? What can you afford to do? And what does the data show that you need to do? Again, some of the findings that we had in our landscape survey of not only HIV programs, but PrEP programs help provide some data nationwide. But what's the data like in your community? What do people need? What can you afford to do in your community? Some of these data points are not prescriptive, but will help you as you make your decisions. So again, keep those in mind. We don't want you to do the world. You can't do the world. It's a business decision, but track and monitor everything that you do to help you make the best decision.
Mm-hmm. Mm-hmm. Well said, Robin. Thank you so much for adding that logic model point and discussion of data capture. We're going to move on to scenes 16 and 19, which will give you some interaction between the navigator and the person at the health department, which will inform our discussion.
About a year later, Francis and Stu on the phone in their offices.
Stu, Francis Holden here. I'm concerned about a patient you were following, Tiffany Stewart.
Sure. She had her baby about 9 months ago.
Well, we haven't had a lab report on her in quite a while. Do you know what's up?
I thought she moved and transferred to the Avondale Clinic.
Not that I can tell. She may have fallen out of care. That's always a risk for new mothers. Can you follow up?
Sure. I'll call you with any news.
The next day, Francis and Stu on the phone in their offices.
Francis, I found Tiffany. Her boyfriend left her, so she moved across town with her sister. She put her child first and just never got back around to her own care.
That's about what I thought.
I took her to Carlos at PARKSIDE Clinic. She's in with Dr. Armand now.
Good. Keep me up on how she's doing. We have to stay in touch with her.
Okay. And so what we have here are a lot of nuances that we would like to try to tease out, just a couple of them. The term loss to follow up was mentioned here. And we would like to sort of highlight that there is no universal definition of loss to follow up in HIV treatment programs. Patient or consumer attrition is recognized as a threat to the long-term success of an antiviral therapy program worldwide. But at what point a consumer becomes lost is subject to some interpretation. And there are resources which we have provided or can provide to you later that give you some indication of what I would say, general thinking around this is. It could be in your programs, missing a 6-month follow-up, or it could be, successively not responding to several calls or emails. It just depends on the workload and the volume of people that you see and the demands on your navigator's time. Because time is a limited resource, and we want to also highlight that navigation work can be stressful socially, and so there is part of your design should be the care, the staff care of your navigators, because the work can be very demanding and clients can be very demanding on navigators. So you want to monitor that as closely as you can. This scene is also noteworthy for another reason, because we have a situation where Stu, who is a male, is assisting a woman who has a child and possibly some exposure to mother-to-child transmission. And we want to make sure that you are just thinking that, you know, part of your navigation work, if it involves females and women who are at risk of this mother-to-child transmission, that would be part of the training and onboarding of your navigator. And so all this, you know, sort of thinking about who is the customer and what are their needs and what are their barriers, and how do we determine loss to follow up. And the other last kind of point that I want to highlight about this scene is we have the navigator in communication with the health department, who is the funder or donor, and it's not clear to us who at Positive Empowerment actually is the supervisor of Stu. So we have a situation where the health department liaison is working with the navigator and it's tasking him to go out and do follow-up on a client. And where is that data recorded? Is it the navigator's role to report back to his or her supervisor about this request from the state, from the Department of Health, rather? And, you know, those data pieces need to be captured. Otherwise, you have people that are doing stuff, and you want people to have take initiative and be self sufficient, but at the same time, you want to make sure you have the data about the needs and the demands that the donor has made or the funder has made on your program. Because you may find that you need more navigators, or you are not using your navigators fully. That kind of information is more of a process information that you also want to collect, as Robin said, about the program.
Four months later, Parkside Community Health Clinic waiting room.
Hey, RJ, Stu again. Where are you? Are you all right? Look, Carlos rescheduled you for 3 o'clock today. Call me when you get this, okay?
Stu, you look distracted. What's up?
RJ didn't show up for his appointment. When I called yesterday, he said he was on board, but didn't sound good. Something's up.
Could be.
And he was really turning things around. I'm gonna head over to his apartment to see if he's home.
Well, I'll go with you. Let's check out his hangouts too.
An hour later, street in Parkside.
Look, it's RJ.
Go talk to him. I'll wait here.
Hey, RJ. Can I talk to you for a second?
I'll catch you later. What's up?
You tell me. You didn't show for your appointment today. You didn't answer my calls.
Yeah?
I'm worried about you. You doing okay?
I'm fine.
Well, you don't look so good.
Oh, man, give me a break.
RJ, come on. Yesterday, you said you'd meet me at the clinic. What happened?
Man, I don't even remember talking to you.
Talk to me now.
So this guy I hooked up with, he had some coke. I missed a string of days of work and got fired. And now I'm trying to figure things out.
Have you been taking your meds?
The guy ripped me off, took my backpack with all my pills.
RJ, you've really started to turn your life around. Don't waste that effort.
This is all messed up.
No, it's not. Why don't we head over to Positive Empowerment for some lunch? Then we can go to the clinic.
Yeah, I haven't eaten in a couple of days.
Come on, let's go.
Okay, and so this scene highlights the importance of regular check-in meetings and follow-on emails and texts that inform your caseload and services that are being delivered. And it's not clear that every navigator would go out and actually, you know, do search and rescue for clients. You know, that's a tall order. And as you can see, that the closeness that has occurred between the client and the navigator is something that's frequently discussed in the literature around social services work, and transference and getting too involved in the care of someone would be something that you would want to be monitor as well. And we didn't spend a lot of time talking about it, but we have this sort of technology issue around, you know, figuring out whether RJ made his appointment or not, or how would the navigator know that? Is someone letting him know, or is he accessing RJ's record in some way or another to determine whether or not he or she is attending their appointments as required?
Four months later, Parkside Community Health Clinic waiting room.
Okay, so in order to minimize or reduce the incidence of loss to care, the landscape survey offered these sort of mechanisms to help minimize loss to care. So if loss to care is one of the indicators that your organization chooses to follow or is following, it's a negative indicator. We want to minimize it. So we want to have a program that takes some active attempts to decrease loss to care situations. And so we find that the most frequent avenue for reducing loss to care is phone calls to consumers, followed by the orange, which is phone calls to an emergency contact. So in your intake for navigation, or in your intake into your community-based organizations programs, you want to make sure you have an emergency contact. You want to also, some of the other things are you send text messages or social media. And of course, you have to get approval or authorization from the consumer to do those things. You just can't do them without asking. So, and the difference between PrEP and HIV navigation is not significant, and the PrEP is just there for your thinking around whether or not your navigation program will attempt to work with people who are considering PrEP or not. And sort of the last point that we wanted to highlight is that we have a situation where Stu and Francis and Carlos, the doctor, are in a meeting and they're reviewing the results for at the aggregate level. We're not at the individual client level. We're at the portfolio level, looking at a group of clients who are in the navigation program and or in the care of whatever the health department is funding. And they're looking at the numbers, and they're saying that the number, that the goal that they're reaching is people who have been diagnosed, and people who know their diagnosis, and people who are in treatment as opposed to loss to care, and people whose viral loads are suppressed. Those are the gold standard for what, those are the gold standard outcomes and impacts that we want our navigation programs to have. And so meetings are a way to get at that. And you could, you have a physical report, but it's necessary for people to have in-person conversations around what the challenges are and what the successes are, and how you measure success and how you celebrate success needs to be part of your evaluation plan. And so we would like to sort of end with offering you some additional resources that are available to learn more about navigation, which is sometimes called community health work or peer navigators, etc. And you can, and PrEP navigation. It just all depends on what the focus of your navigation approach is. And you get to sort of pick and choose those things. And I will turn the mic back over to Robin to close.
Thank you, Eric, again, and appreciate the time that you've taken in going over this. Just want to just underscore a couple of things that you said in the presentation. That is that navigators are part of your team, and as everyone looks at his or her navigation program, or as you consider developing a navigation program, consider the oversight of the navigators. And something that Eric mentioned, who is really providing oversight for Stu? Stu's out there doing a lot, you know, giving bus tickets and, you know, taking, as Eric said, doing sort of going out really trying to rescue this one particular client. But there has to be some oversight for that, and that has to be documented, and that has to help, and that should be documented, not to be punitive to Stu because he's doing an outstanding and exceptional job, I'm sure, but to understand how much of his time, what is the burnout rate for somebody who does something like that, and how many navigators would you really need to accomplish your goals. Again, to underscore what Eric mentioned, at the last setting, that group discussion, again, the partnership, and how do you evaluate how well your partnership has gone? You know, if you don't have a Stu, or if you do have a Francis or someone who's in the middle, you know, how are they evaluating each other? That's something that's worked out at the beginning, but each person should sit there and should think about, what is my role? What is my responsibility? I say all this to say that through evaluation, you can look at the levels at the macro level, but you can also look at your own organization, analyzing, evaluating how well did your staff do, then looking at it in terms of collaboration, how well are you all doing playing your role or putting your part in terms of this navigation program or this training. NMAC has created, actually with Eric, through Eric's work, several tools, fact sheets about evaluating navigation programs, supervising navigators, looking at some of those components in terms of personnel issues. Moreover, we're looking at helping you all to understand some of the specific, we mentioned the logic model a lot of times, and people have known and done logic models for years. CDC has the logic model sort of overview, looking at the components. That has recently been posted, so you'll have that as a download. I want to make sure you understand what is available when you download the files. So you will have not only the resources there, but we have placed in the download box the slides from today's presentation, the actual NMAC landscape survey of PrEP and HIV navigators, and finally the CDC components of the logic model. Again, most people are familiar with logic models, but as we were talking about it more in the abstract, is how to use the data. This reminds you of what kind of data to provide in a logic model. What is the output? What kind of numbers or what kind of information should be placed in that outcome column or component? What is outcomes? How many outcomes are you expected? And what does that look like? So that's already been uploaded. So again, NMAC will be and continues to provide capacity building assistance to assist you in not only your navigation program, but also in evaluating the navigation program and even evaluating the navigators. We will have more webinars sort of forthcoming that looks at sort of breaking down and understanding more the tools that we are providing for you. But we appreciate your time on this webinar, and we want to thank you very, very much for your attention. For further information about our services, please contact us at link@nmac.org, and have a great rest of your day with navigation.